Very much. Thank you very much. So, I'm talking today about immediate molars, basically immediate implants in the molar zone, in the molar socket, and how to do this predictably. And the reason I've chosen this topic was because, I'm not ashamed to admit, I actually had a little bit of trouble with this particular procedure. And I was having more failures than I would like, and I basically stopped doing it. And I thought, let's just leave everything to heal. It's not a big deal, it's just a molar. But I'll talk you through why I changed my mind, what led me to go back and look at this again, and how I learned to do it more predictably. So, just to briefly outline what we'll be talking about today. Firstly, we'll look at the evidence for this procedure. We'll look at the advantages of doing it, so basically why it's done, and then also how to do it. Okay, so we'll look at the classification for the sockets to ensure that we gain our primary stability, briefly touch on dual zone grafting, and then the thing that really changed it for me, which is the custom healing abutment. That's what changed everything for me. Right, so the evidence. So it's not a new thing. We've had published papers for over 35 years on this topic. More recently, systematic reviews showing that the survival rates are actually the same for healed sites and immediate sites. So obviously it was something wrong that I was doing. And what we also found was that the bone levels were better in immediate molar sites. And interestingly, the Ragucci study in 2020 showed us that grafting the socket really helped with our survival rates. So we'll take that on board. But then the question is why? Why are we doing this procedure? Why not wait? So obviously the sockets collapse when we take teeth out. We lose hard and soft tissue. We also can save time. We can reduce the number of appointments and obviously reduce cost. It's often a flapless procedure, so there's less morbidity for the patient. But then, when you get failures, and it wasn't every single case, but you end up losing more hard and soft tissue, you end up using more time, using more appointments, costing you more, and actually the patients are in more pain. So again, I thought, well, let's just park this here and we'll come back after 3 months. What changed it for me was actually understanding that using a custom healing abutment ensured that the treatment firstly worked, and we ended up with much better soft tissue profile. We ended up with the papilla maintained. Now you might be thinking, well, it's a molar tooth. You know, who cares about the papilla? We're not talking about the aesthetic zone. I care about the papilla. I'm sure most of you care about the papilla, and also food packing cares about the papilla. Because what we often, and I can only speak of my own cases, when I leave sockets to heal, and I then try to restore them in the molar side, often end up with a slightly compromised result, where you give the patient an incidental brush for free, and you say use that after every meal, and just make sure you clear everything out. But by maintaining the papilla, we can reduce this complication and this problem for the patient, and give us a much better result. So let's look at the principles for immediate implants. Now, I won't bore you with the details, but essentially we need to, in the same way we look at single-rooted teeth, ensure that the socket is suitable. We need to ensure that the implant is placed in the correct 3D position, and that we're gaining our primary stability from somewhere. Now, with single-rooted teeth, we end up using longer implants and preparing beyond the apex of the socket. We obviously don't want to do that for molars because of the vital structures, the ID canal, the sinus, etc. So this Smith and Tarnow classification helps us to kind of understand our different sockets and understand where we're going to achieve our primary stability. So they split everything into 3 different types of sockets. A type A socket is where that interradicular bone, the bone between the roots, is wide enough to house the implant. So the implant goes completely into that bone. Unfortunately, we don't get many of these. The most common type of socket is a type B socket, which is the case I'll be showing today, where the implant is secured into that interradicular bone, but some of those threads are exposed into the sockets. And then you have a type C socket, where hopefully it's not because of us, because of the surgeon, that the interradicular bone is missing. It's because the roots were fused. And you end up with a much wider implant. And you gain your primary stability, again, not apically, but from the socket walls. Now, we've got to be careful here, because that systematic review I showed in 2016 actually showed that using the super wide implants, anything more than 6 millimeters, had a slightly increased risk of failure, 3.67% compared to 1.45%. And the reason for that is most likely because those implants are compressing what could be a thin buccal wall. And what we often find with fused roots is that there is a little bit of bone where the roots furcate. And actually, you end up with a situation like this, where there is a little bit more bone in the middle of that socket, and you want to use a wide enough implant to engage that bone, but not necessarily destroy everything. So this 67-year-old female presented to the clinic with a failing lower first molar. We can see the apical radiolucency, and that was secondary to a fracture. She had a vertical fracture right through the tooth, and unfortunately, the tooth had to be removed. This is a section through the CT scan. We can see that fracture running all the way through. And we discussed the different options as what to do to replace the tooth, and she decided on an implant, an immediate implant, in fact, for all the benefits that I've just spoken about. So I always break this down to the patient. I say, look, we've got 3 steps here when we come to do the treatment. We've got the extraction phase, we've got the implant placement step, and then we've got the custom healing abutment. It helps them to break it down. It helps me to break it down throughout that appointment. And they're all just as important as each other. So the extraction must be done atraumatically. Very simple. We just section through, separate the roots. We use fine luxators to gently elevate the roots out. Okay, in this case, the lingual fragment was removed, and the tooth was sectioned. Once the tooth comes out, we want to obviously clean and remove the granulation tissue, and we can see we've maintained that interradicular bone. This is where we're going to stabilize our implant. So phase 1 is done. Tell the patient, okay, we're going to move on to phase 2. Let's prepare and place the implant. So we prepare into that interradicular bone using a very sharp lance burr, because we don't want to slip into the path of least resistance, which is into the mesial or into the distal sockets, of course. And the same applies when we're placing our implant. We want to make sure we're getting it into the right place. And we need to achieve a decent primary stability. So for this to be predictable, we know that we need at least 15 Newton centimeters. In this case, we achieve 45. So we know everything's quite stable. We've placed the implant deep enough to give us 4 millimeters of soft tissue height, and it's in the correct 3D position. Yes, I will graft. I'll come back to that. The next phase for the patient, I tell them, look, the surgery's done. Let's move on to making the custom healing abutment. So quite simply, a titanium cylinder is placed, and flowable composite is used to incrementally build up this web around the socket to outline the shape of the socket and slowly fill in so we form a socket sealing device. So this is going to help stop anything getting in, getting out, and also maintain the outline of the socket and keep what we have. This is then removed, and yes, I know it's not a pretty sight when you first take it out, but then you just fill in with some more composite. Way too bulbous. So we need to prepare this, we need to shape this, we need to think about our emergence profile. So we need to make a more concave shape to our temporary, custom healing abutment. And then we clean everything up and polish it and leave that to one side. Let's go back to the implant. So the implant driver is placed, and then we graft into the sockets. But we don't only graft into the sockets, we graft a little bit higher up into the soft tissue as well. The dual zone grafting technique, as described in 2012 by Chu, which actually was on an anterior case, talking about the jump gap and grafting up into the soft tissue zone and producing a much more aesthetic and stable result. Now, we're not looking for aesthetics here, but we are looking for stability in our soft tissue. A more recent randomized controlled trial done earlier this year compared this to connective tissue grafting and actually found the results to be very similar, but it's much simpler to do. So this is done. We then grab our custom healing abutment, secure that back into place, PTFE and composite to seal. Do you need sutures? Sometimes you need it. I like to do it just to hold everything together, and also it just reminds the patient that they've got to keep away from this area and protect the site. Immediate post-op radiograph shows that the implant is shorter than the apices of the roots of the socket. We're not going beyond the socket. We're securing it into that septal bone. We can see the emergence of the custom healing abutment, and we can see the graft material in the soft tissue zone. Fast forward 3 months, nothing's really changed in the soft tissue aspect. Everything's quite stable. And when we remove that, we can see that we've got this beautiful emergence profile, maintained upper pillar, we've got a long running zone into our implant, really thick horizontal and vertical soft tissue, which will protect the implant and keep things more predictable in the long term as well. So we take the impressions and we send them to the lab, and we have to be clear with our laboratory, and we talk to them about the subcritical contour. again, needs to be concave. And then the final millimeter, the critical contour, needs to be convex. This is what's going to help and support our soft tissue position. We also need to ensure that there's no glaze in that subgingival area, as per Lenkivicus. That we want to keep it zirconia, highly polished, or super polished as he calls it, with no glaze, but it has hemidesmosomal attachments that will be achieved. Again, giving us that long-term predictability. This is fitted in a normal way, and we take a radiograph. Sorry, we can see that the papilla is stable, nothing's really changed there. We take a radiograph and we compare that to what we can see a year later. The bone has matured. Sorry, I better get out of the way here. The bone has matured in the socket. We've got stable bone levels around the implant. And we can see that the contours of the crown are correct as well. And even when we look at it clinically after a year, we notice that the soft tissue has really matured around that zirconia crown. It'd be very difficult to probe around this area. So quite a stable result. And as I say, what changed it for me was this idea of using a custom healing abutment. Because the problems I was having was that graft was leaking out, food and bacteria were getting in. So it solved that problem. But also, we know that we have better papillar indices, and we have much better bone levels as well, reduced bone loss. This is what I was doing before. I was placing a healing abutment, quite a wide healing abutment, onto my extraction site, and wrapping up with loads of sutures and trying to bring everything together. Not ideal. It worked. I mean, it does work sometimes, but we're talking about predictability. We want it to work every time. And some of you might be thinking, well, Megagen do a 10 millimeter healing abutment. And they do. And it is better, but it's not ideal. Because still, it doesn't really seal everything properly. And if that implant was slightly more lingual, then we've got a bigger gap opening buccally, and we've got the soft tissue being pushed to the lingual aspect, which isn't really going to help anyone. And the same applies for the new anatomical healing abutments. Same thing. You can't really beat a custom-made healing abutment. It fits perfectly into the site, maintains the soft tissue exactly as it was, keeps the papilla, and stops anything getting in or out. So it was a real game changer for me. So in conclusion, I'll go over the 3 steps again, because these are the important steps that we talk to our patients about when we're doing the procedure, but obviously to bear in mind what's going to make this work. So the extraction, very, very important. We have to section the teeth. We have to take the teeth out atraumatically to maintain, obviously, the buccal bone, the lingual bone, but also the interradicular bone, because this really is where we're going to be placing our implant and where we're going to be gaining our primary stability. Keeps it flapless as well, which is really important, just in terms of post-op pain, etc. We then look at the implant placement, so we've got to understand that classification to know where we're going to place our implant, which implant to use, what size implant to use. We need to then ensure that we're getting that primary stability of at least 15 Newton centimeters. And yes, we need to graft. The evidence does show that we need to graft the sockets. It does give a much better result, and dual zone grafting, even better. And then finally, I said it already, but the real game changer, the icing on the cake, the holy grail, the custom healing abutment. Yes, it does take time to make. You get quicker at it, but it's worth every second. It ensures that nothing gets in, nothing gets out. It ensures that the bone levels are maintained. We have much better marginal bone levels and much better papilla index scores as well. Thank you very much.